So I'm very pleased to be here, and I'm going to talk a little bit about stress and drugs in vulnerable boys and men and how it matters to you and me. So I'm going to briefly describe drug use in boys and men of color and sexual minority boys and men, describe reasons for drug use in vulnerable boys and men, and identify evidence-based and promising approaches to drug use prevention and treatment. When I started with this at APA, we first said we were going to do health disparities in boys and men, and I am a member of the Division on Women, and a lot of the women came in and said, well, why are you looking at boys and men? There is much more power and privilege in that group than any other group, which is generally true. I said, well, we want to look at groups that are underrepresented and underserved. And so as we started defining that, we tried to come up with a way of capturing that group without having to list every group that fit under that umbrella. And so we came up with vulnerable, and I'm getting ready to pay for it because we're trying to get our report out, and 2 of the review groups said, I don't like that word vulnerable. It makes people feel too weak, and you're not acknowledging their strengths. And we were thinking of vulnerable meaning what is happening out in the world that they may be vulnerable to, rather than a reflection. So just some ideas, and knowing the work that we go through whenever we're in behavioral health or whenever you're working with people in treatment, of what the terms mean and confer to them and to those people with whom you're working. And so we've been trying to negotiate the language and the concepts as we really are pushing for working with collaborators. So most of my work has been in health disparities. We have this one to show that equality means that if everybody has the same kind of platform, sometimes they still don't have access to the same kind of opportunities and services. Equity means that sometimes people need more of something else to bring them up to that same point. So health disparities in general, essentially what we're looking at is that health disparities are systematic health differences that adversely affect certain groups. They are preventable and avoidable, and they are modifiable. They do not refer to all health differences. And what the problems that sometimes we get into is that any difference in health is not necessarily a disparity in health. The example I use for myself is I have the sickle cell trait that makes me a little different, but it doesn't necessarily mean that it was a result of a disparity. So the fixes or remedies when we're trying to address health disparities usually means that it will have some benefit for a whole group, not just that individual person. So we're interested in eliminating those kind of differences, even though we're still focused on health equity, which means that I want everybody in my community, everybody to have the best optimal health possible. That is not going to be achieved, however, if we close a blind eye to the disparities and the gaps that really exist. Now, we did a multidisciplinary group, which is a little bit different at APA. Now, it's a little bit different for a practical reason. Usually we bring in psychologists because we don't pay them. We ask them to do all this work, we don't pay them. Because they're members, they do it. When a multidisciplinary group, we figured that if we want to look at boys and men, and we want to look really at any group, we wanted more than one perspective. One person that's working in one area would not have the whole picture. So we actually did a multidisciplinary group. It was a group of about 10 or 11. There were social workers, an MD, psychologist, a public health official from different parts of the country. It was really one of the most interesting groups that I've worked with, and they were so passionate for what they did. But as you can imagine, it was one of the hardest things to do to get to some agreement on what would go in that report. So they decided to look at boys and men of color, sexual minority boys and men, and to focus on trauma, substance use, violence, and depression. And they did some recommendations. I'm going to pull some from that report as I share with you some of the findings and how we were starting to think about substance use. Some of the guiding frameworks they used were social ecological models, life course developmental models, environmental affordances model, stress and masculinity, and really wanted to look at intersectionality as key, that you have to look at that whole person. Most of you are familiar with some of the models that are there. Usually people in behavioral sciences are. I'll talk about one of them in particular, which is the environmental affordances model. I think I have an example of that. Okay. We did a little bit of definitions. How many of you know what stress feels like? Okay. All right. So even if you can't define it in a really succinct way, almost all of us know what stress feels like. But it's essentially an environmental demand that takes you beyond your resources. And a stressor is any physical, social, or psychological event or condition. I won't go through that because I think most of you would know that. How many of you know what manhood is? So this is a lifespan developmental issues and role strain and adaptation. I'm just giving you a quick example. I'm not going to go through this. But we were trying to look at men, boys and men, specifically boys and men, kind of across the lifespan. And I'll give you another example a little bit later of a difference that it makes and what you have to look at from early childhood, really always to old age. And I'm not, like I said, I'm not going to talk about it, but I want to give you some of the ideas that help form this group. The other idea of this masculine balance. Manhood in part has to do, especially for some of the people you might work with and people who are having a problem, respectability and reputation. And achieving a level, and sometimes that respectable is achieving a level of economic success, educational attainment, and social class status. And they're trying to be respectable and live up to an image. But that reputation, what is your reputation among other men or within the community? And sometimes that can bring some issues. And that's where sometimes we have this issue of that kind of conflict and how we view males and masculinity. This intersectional approach that I talked about is, how many of you are tired of seeing these really busy slides? I'm going to show you some more with all of these interconnections and with race and gender and where you live and your physiological responses and what that means and all these arrows pointing to you. But it is important that we have to recognize that and we have to bring people in who understand that. Can anybody give me one good reason why these slides look so complex? Because I'm going to show you another one. Because we are complex. So if I put one slide that this leads to this, leads to this, it wouldn't capture any of you. Are any of you that simple? This was just an interesting fact. That some of those things that we think that we know about people that fit with one person, so that intersectionality is usually the more money you have, the healthier you are. The more money you have, the more access you have to things. With certain groups, that's not always true. So the thing I'm trying to is we cannot always assume that one thing that's true for one person or one group of people will be the same for everybody else. So that elevated health risk persists for men. And this is the men in general at all levels of SES, particularly men of color. So that if you have more money for women, it's more likely you'll be a little bit healthier. That's not the case for men, African American men in particular. This is the environmental affordances model. Environmental affordances means that essentially this is a model that says what is out in the community will help prepare you and help protect you. So if you have some things in the community that affords you some benefits or some opportunities, the better off you're going to be. So I'm not going to go through all of these things, but there is some wonderful work. James Jackson has done some wonderful work on looking at environmental affordances and what it means for people of color in particular, and it doesn't work quite the same way for everybody, okay? But you see chronic stressors are in there, stress-related psychopathology. And these were the kinds of things we were looking at. We were really honing in on the stress part of that. All right, that was just some preliminary work. Now I'm gonna get into hopefully some more specifics. There are 4 phases of health disparities work, but I think this is true for any work that you do, whether it's an addiction, any kind of mental health work, or any kind of research work. that you have to document, understand what is happening, what you're seeing before you. If you're seeing somebody that, for instance, that comes in an intake, you try to figure out what they're using, how often they've used. I mean, there's some questions that you kind of go through. The other thing, though, and as a country, we try to document to see the health of the country. So we have these assessments. The president does a State of the Union. We have this kind of history of trying to figure out what we are seeing, what's in front of us. The next thing, though, is understanding. We have to try to make some meaning to that data and what we see. And then from that, we develop interventions and we implement those interventions. And it is cycles of it because human beings do not stay the same. So those things change over time and we go up and down. Somebody's going to be talking about the opioid crisis, I believe. How many times have we had an opioid crisis in the country? It's a little bit different now, but it's not, for most of you know, most of these things aren't new. We kind of go up and down with this. And so we have to keep kind of chasing that data, observing what happens, and then trying to understand it. What I want to talk about today, and I'll bring it up, is people who I think are thought leaders and making us kind of look at things a little different. And I think some of you probably have seen that too. You in your own work, and you've looked at what the protocol says, what the treatment is supposed to be, and you kind of, something's not quite right with that, and you're trying to give words and meaning to what you see. Okay. So documenting. So you know, in this country, we have some requirements for public data collection. You have to show that you have the need for your state block money, your city money, for your treatment centers, for your donors, and you have to keep those kind of records. Now, for race, gender, we didn't always do it by race. And sometimes we didn't do, how many of you remember when NIH, a lot of NIH studies did not include women? Yeah, the inclusion of women only happened, that was required, I think, in the early 90s. Because women, according to medical researchers, messed up the data. You know, they got cycles and they are moody and they're, you know, so, you know, you can't be, you know, given this precise kind of treatment and then you have these people with other things that's going to interfere with it. But that, can you believe that that was true? So now there are requirements for that. There are requirements to include children because children get sick. And we don't know how some of those treatments worked with them. So some things we kind of assume now. Somebody actually kind of thought and said, this doesn't make sense. If, in fact, it is true that those cycles mess it up, then maybe we need to understand that because we still need to be able to treat, we're obligated or should be obligated to do that. So other things about documenting is that we need to gain the trust of the community. We need to ask the right questions. Now, this happens a lot with women, and it happens a lot with people from different cultures. That sometimes we don't think that people are asking the right questions, so you keep getting the wrong answers, and you keep failing a lot. Knowing who to ask, protecting the use of data, and money and support to do the work. Now, the quality of the drug use data resources. Now, I'm not saying this because I worked at NIH and NIDA, because there are some problems there. However, I will say that with drug use, we probably have a pretty good data collection system. I mean, it can be tweaked, it can be improved, but we have the National Survey of Drug Use. It's Drug Use and Health by SAMHSA. The Monitoring the Future, which is done through the University of Michigan, which looks at drug use in adolescents. The National Epidemiologic Survey on Alcohol and Related Conditions, which is done by AAA, Centers for Disease Control, supports the national health, and the NHANES study, and there's a national. So we have these data sets that really are pretty good at telling us what the data are. When people use, what they use, how old they are when they start using. We can be pretty confident about that. What can't we be confident about? How to interpret it. Are they asking all of the right questions? So we can kind of know some of that. And then we get people that, and reports that come out. Facing Addiction in America, the Surgeon General report came out not too long ago, talking about drug use in America. In 2015, 27 million people in the United States reported current use of illicit drugs or misuse of prescription drugs. Over 66 million people reported binge drinking. Now, what I'm going to be talking about a little bit, just to make the observation, is that when you look at those legal drugs, we spend a lot of time looking at the illicit ones. Which ones cause more harm to more people? The tobacco and alcohol is illicit drugs. The amount of mental retardation for children born tends to be from alcohol. And I'll show a little bit, and most of you already know this. That's why I'm hesitating a little bit to give a lot of data, because I think most of you know that, but I wanted to make that point. I've just put heroin use in here because of the opioid. I didn't want to put some of the images, but heroin used to be kind of one of those drugs that people used to use a lot, especially associated with the music scene and the blues and the jazz singers. In certain communities, and it was viewed differently then. So it kind of comes up and down. But one of the numbers for that, past year use of heroin is about 0.3%. So we're not talking about the numbers are going up, and that somebody will talk about that later, but we aren't talking about a large percentage of people who use that. So this is a slide from SAMHSA. And the thing that I wanted to point out for this one is, if I could flip it up, you can see that little cone shape in there, in the circle. How many people do not use illicit drugs in the past month? 90% of us do not, okay? And then about 10%, usually past month is about the standard that's usually used, use illicit drugs. So the good news is what? That 90% of us don't, about 10% of us do, and what do those 10% do? They drain a lot of resources. Okay, here's just some general facts. Men use drugs more than women. Everybody here pretty much knows that. Men age 12 or older are more likely than women to report illegal drug use, and more women than women ages reported using marijuana. So essentially, and this has been true always, and we're going to get to some reasons for why that is true. That has changed a little bit in the last maybe 10 or 20 years, that women are starting to use more. So I'm not saying that women don't use, but the general pattern is that men use more legal, illicit. Women have started using more, especially two groups of women, which was young adolescent girls, and actually some young black girls a few years ago. Anybody know why? It's really a really easy one. Availability and access. It's just easier to get to it now, okay? And women often would use through, now everybody knows this one. How do girls get usually introduced to drugs? Men, boys, a little bit older. So illicit drug use in boys and men of color. The most commonly used illicit drug is marijuana. That's true for just about everybody. And the rate of current illicit drug use is, and look at these numbers, 3.1 among Asians, 8.8 among Hispanics, and this is from NISDA, National Survey on Drug Use and Health. 9.5% among whites, 10.5% among African Americans. And the thing that I wanted to know is that if groups that sometimes were hidden, if you looked at Native Hawaiians and other Pacific Islanders, at one point they were grouped with Asians. So if you see, when we can pull the data out and look a bit more closely, we can start seeing where the differences are. So sometimes we're working at a disadvantage because we really didn't know what was happening within particular subgroups. We kind of clump people together. We still are in a way, we need to pull that out, but at least we can start seeing the differences there. This 17.4% among mixed race persons, people who identify as mixed race almost always look worse on behavioral health profiles, mental health profiles. There can be some interesting speculation as to why that's true. So these numbers are high. What surprises people sometimes is that because of the image in the media, they almost always think that the African American group or the Hispanic group is going to be on the highest end of that. Just those perceptions, and that's not true. Illicit drug use. African American youth tend to be later onset users. What does that mean? It means that if you start looking at monitoring the future or some of the other data, you'll see white youth in particular start using a little bit earlier, and black youth will start using a little bit later, but sometimes progress a little faster or get into more trouble with it. Remember, these numbers are still kind of small. White males drink more, followed by Hispanics, Native Americans. So it is important to look at these data and to come up with some interpretation for that. That late onset uses for African Americans has been tied sometimes to authoritarian parenting styles of African American parents. And that's one example. And this has been consistently kind of found over the years. Substance use in sexual minority males. Gay and bisexual men are more likely to use and abuse substances than heterosexual peers. More likely, LGBT individuals more likely to use alcohol and drugs and continue heavy drinking into later life. Use of party drugs, part of that cultural thing. If you go to parties, they might use more meth, GHB. Note there's some data limitations when we look at sexual minority youth. Men. And any reason for that? Most of us know those reasons. Yeah, sometimes you don't want to reveal, and some won't let you ask because you're not sure what the political or programmatic consequences will be if label people. I'm going to talk about a little bit of smoking because we got a bigger project, and you can see again here that when there's lots of difference about smoking, no matter what, there's going to be more severe consequences. Okay. African Americans, diseases from smoking, this is one reason I'm putting it up here, kill more African Americans each year than car crashes, AIDS, murders, drug, and alcohol abuse combined. How many of you know that some of the research says that if anybody has an addiction, in particular if you're smoking, that your outcomes are better for all of the behaviors if you treat smoking? Smoking is one of the hardest things to treat, yes. So we're getting some research that shows that you need to treat it all. So the consequences of substance use, you all kind of know this. There's the top 7 causes of death in the U.S., the cancer, the heart disease, HIV, AIDS. Adult males, 3 times as likely to drink and drive as women. With young adult Native Americans and white males at greatest risk. I did a talk, it was in Montana, and I was working with a younger group. They were like kids. And so we were trying to come up, I forgot the question, but it was some question that I didn't think they would get high incidence on. So I asked how many had been in a hospital. We were looking at traumatic experiences. And almost all of them raised their hand because almost all of them had been in a car accident or had knew somebody in a car accident because there was so much drinking, driving, and those rural roads. And so it was really surprising. I hadn't thought through having to know the community that I was in, what that trauma would be like. Okay. All right, that was the slide that's out there. I'm not going through that now. Smoking in blacks. So the other thing was, the major conclusion I wanted is smoking, the consequences are not the same. They're going to be more severe often for people who are underserved than they're going to be for other people. And the same behavior does not equal the same risk. And just remember that there was Wallace did studies years ago. Even in school, if somebody was caught doing, say, smoking, the risk that like detention or staying after class, whatever it was higher if you were a person of color than if you were white. And that tends to just follow through, that the same behavior does not equal the same risk and the same consequence. Okay. So we have about 15.7 million people in need of treatment for an alcohol problem in 2015, and about 7.7 million needed treatment for illicit drug a problem. I'm going to skip over some of this. So I talk about documenting, so we kind of know what the need is, and even if it's that 10%, we know that 10% can drain your resources, and they really need it because we want them to be healthy, getting back to their families, and there's lots of research that shows what happens to those families. But the other thing is, how do we understand and interpret these data and experiences? I've talked a little bit about some of the conceptual frameworks and a little bit about the authentic experiences of what happens and how do you go and know that something is not right and how to understand it and to make it better. And I'm going to talk about two things. I put this slide, I just pulled it, this war on drugs. 2/3 of persons incarcerated for drug offense in state prisons are African Americans and Latinos. I don't think that's changed very lot. Okay, so I knew Carl from NIH when he was a postdoc. And he says, I highlighted this, is think counterintuitively. I kept a gun in my car. I engaged in petty crime. I used and sold drugs. Today, I'm a professor at Columbia University who studies drug addiction, and what I've discovered can be used to produce a more humane and effective criminal justice policy. That's Carhart. Okay, and so what he's saying is that you have to really think about the messages that we give people. And so he's done a lot on sentencing disparities and just moving forward. So why do people use drugs? This is oversimplified. I'm embarrassed to do it because of people, all of you have such expertise. But two major reasons. One is to feel good, and the one is to feel better, right? The feel good is that kind of thing that we do in normal social settings, expectations. Feel better, that's your 10%. Self-medicating, they may lead to abuse and addiction, and they're doing something to heal themselves, to just free themselves from something. Okay, that's Snoop. So these factors contributing to substance use in vulnerable boys and men, that normative male culture kind of thing, military fraternities, it doesn't mean everybody. We're on a college campus, we know what drinking is like, for instance, on a college campus and other kind of use. And then, but we wanted to look at stress and stress exposure. So masculinities and gender stress, when people have a role strain that I showed you, if you don't think that you can be the provider that you thought you should be, does it create some tensions for you? And these other stress exposure, discrimination and prejudice, microaggressions, acculturative stress, people trying to fit in, stereotype threat. I'm assuming some of you know what these are, economic stressors, hostile environments for gay youth, lack of health insurance. Implicit bias, has everybody taken implicit bias tests? Most of you kind of know about that. Stereotype threat and microaggressions. Often you experience them almost every day. And so for people who can perceive it, whether it's there or not, but they actually do experience it when the cab doesn't stop for you, when somebody won't touch your hand when they give you the change, where they question maybe where you're from, as if you are not from this country. Okay, there are lots of ways that that's there. And those are the types of microaggressions. So I'm not going to go through, because I want to get to one other part. How it affects you is in that facing addiction in America, neighborhoods and communities are suffering, long-term health effects, long-term societal effects, the direct medical costs of health inequalities, the economic burden for African American men and Hispanic men from health issues has been, there's a whole report on that was done by professor at Hopkins, who is also on our multidisciplinary working group in the millions of dollars. Kamara Jones talks about another thought leader for me when she describes what it is to set up these safeguards. So most of you are familiar with her gardener's tale, when she talks about how if you're a gardener and if you give good soil to one plant, but not such good soil, place them where you place them. If you water them and they're in the sunlight, and another plant this way. And she came up with this because she noticed some plants that were left at a house that they had bought, and why some did well and some didn't. And she kind of took that allegory to how we treat people. So if you put people in soil that is not rich, and they can't see the sun or the sun doesn't reach them, then you get these different outcomes. And the other thing that she did was she talks about this walk, and I'm going to tell this story real quick. I'm going to go over my little time. You are walking by the James River, and a group of you, and you start seeing a child in the water. And somebody goes in and pulls out that child and starts doing CPR on the child. Then another group continues walking. They see another child, and they pull him out. And they come, and they see another child further down, and they pull that child out. So my friend here, it stops helping them pull these children out of the water, and they get very upset with you because you're not helping that child pull out of the water, and you disappear. And they finally, when they keep pulling these children out and rescuing them, and they catch up with you and they ask, "What were you doing? Why didn't you help us?" And what was his answer?
Who's throwing the kids in the river?
How all these children are getting in the river. And so one thing we have to think about is what roles do we all play? Are all of you, is everybody going to be that direct service provider that keeps pulling the children out? Or we have roles for people to try to figure out, do we need a fence by that river? Okay? And I'm going to give an example of these approaches, upstream approaches, which are policies, midstream approaches, which are more programs, and then approaches that are aimed for the individual. And so everybody can't keep doing the individual. We need people at the individual because they need help, but we need to keep them from getting that far down. And so how do we do that? So the most effective prevention efforts are going to be, and I gave the example of smoking. How have we been able to cut smoking in half since 50 years ago? We restrict the use, we restricted tobacco marketing, we banned smoking in public places, we required tobacco companies to label the packages, we put taxes on them, they invested money to support tobacco prevention, and created laws. Anything up there about what they did for the individual. These public health efforts are the most effective that we can do, where we create an environment that protects people. So that I don't have to make that choice all the time. I have something that helps me make that choice. Okay, and so when cigarette prices come up, sales went down. Restricted advertising. I just want you to read that. So the effective substance abuse interventions, some of you have these already. We know how to reach the individual. We know we can improve on those. Those specialty courts, I wanted to put them up there because those specialty courts are sometimes not accessed or used for people of color as much. And there are reasons for it, but we can talk about that later. But there are some programs that are available that are disparately used. Okay. And then there are lists. You can go and find these evidence-based practices for people at the individual level. Sometimes people use them, sometimes they don't. Heroin, methadone, some people don't use because they don't believe in it. So evidence means what you're willing to believe and what you can use. So what's most needed, I think? Jobs to decrease economic incentive, an end to some of those stressors related to discrimination, reduction in trauma and violence. But I think that's what we need are more gardeners. We need more leaders like you who are going to be able to work at all levels, upstream, midstream, and downstream. And most of you are in a position to be able to do that. So it is not that we're saying that people don't need to be right where they are, holding the hands and helping people where they are there, but you have the knowledge and expertise to make those compelling statements to try to influence what happens at the policy and program level. So these were just examples of some other kinds of things that people are doing, and I won't go through those. And I wanted to just end on a couple of quotes. One is Power that I like by Wade Nobles. And if you're familiar with Wade Nobles, a psychologist helped founded Association of Black Psychologists. Power is the ability to define reality and have other people accept your definition, right? So that's what we have to do. We have to start defining the reality of the people we serve and try to get others to see that vision that we have. And my great philosopher, Richard Pryor, for those of you who remember that comedian, tell me some lies so I can stop thinking about the truth. That sometimes we escape because that truth can be so overwhelming to us. Right, thank you very much.